Welcome everybody to the clinical case conference today. And this is organized by UROD, which is an initiative of the CKD-MBD working group under ERA. We have an exciting case today, and Marie-Helene Lafage-Proust will be presenting the case. And she is a rheumatologist in Saint-Étienne in France. And then we have two esteemed panelists. We've got Neveen Hamdy from the Netherlands. So Neveen trained in nephrology and endocrinology. And her history in CKD-MBD goes back to the 1980s. And now she practices in the Netherlands and still very active in terms of research, not just in CKD-MBD, but also osteoporosis and other rare bone diseases. Our other panelist is Pablo Urena, not from Spain as on the slide there, but actually from Paris. And he is also a nephrologist and chief of the dialysis unit in Paris, and very strong research track in CKD-MBD. So we're very lucky to have both of them here today with us. Now, if I can just ask you very kindly to put your any questions in the Q&A rather than the chat, so then we can address your questions as we go along. There are also some pre-submitted questions. If we have time, we'll go through them, but I will prioritize the Q&A today. So if I can just have a quick time to, oh yeah, I've already done introduction and welcome. Just to tell you a little bit more about UROD initiative. So we started in 2016. Peter Evenepoel from Leuven led is still leading the initiative. So the main thing, the main aim is to revitalize bone biopsy as a clinically useful tool for us to diagnose renal osteodystrophy and decide on management options. We also have a virtual database where we've collected data from various centers in Europe who have done bone biopsy and other bone imaging modalities in advanced CKD. The other aim is to collaborate amongst us, the researchers within Europe who are interested in CKD-MBD, but also to collaborate with other bone mineral societies, for example, in North America and South America. And finally, and very relevant to today, is we want to improve and share our knowledge in managing patients with renal osteodystrophy. So this case conference is one of it. The initiative also has published a number of consensus statements. So a lot of work has gone into this, into publishing these papers, so worth having a look at. There are also several others which are in progress at the moment, so keep an eye out on them. They usually come out in NDT. Now, the other educational program that UROD organizes every year is this UROD Winter Meeting. It happens every January, so put the date in your calendar for 2025, and we always have it in Leuven. I think the meeting has gone from strength to strength every year. So I would highly encourage people who are interested in CKD-MBD to come to the meeting next year. So here we are. I am going to stop sharing my screen and I'm going to let Marie-Helene share her screen.
So thank you, Syazrah, for this introduction. I'm very glad to have been invited to present this very interesting case. And this is my slide of disclosure. I don't have any conflict of interest with this presentation. Okay, so let's begin. So it's a story of a male patient, was born in 1962, was an ex-construction worker. He was a heavy smoker and still smoking half a pack a day. And he had a long history of hypertension and also a history of post-traumatic thrombosis of the right renal artery. So in 2014, he was hospitalized with ischemic stroke with right hemiplegia. related to a very heavy carotid atheroma. He had also, during his hospitalization, a cardiac ischemia, but no myocardial infarction. And ever since his stroke, he was walk with a wheelchair for going outdoor and can walk inside his apartment with a rollator. And during his hospitalization, it was also discovered that he had a CKD with related to nephroangiosclerosis, with a creatinine serum levels at 250 micromole per liter. In 2016, the creatinine level increased, but it was lost of follow-up during 2017 and 2020. Eventually, in 2020, was referred to the hospital where we found he was in a terminal stage of CKD and was put under hemodialysis. Retrospectively, when we read the file, we found that he had a vertebral fracture of the first lumbar vertebra on a CT scan report that has not been performed for this purpose, but for other purposes. And nobody addressed the question of this fracture at this time. I have to mention that you have a preserved residual diuresis that will remain for the whole duration of follow-up. And precisely is a living condition. He lives alone in an apartment with help 3 times a week. So this is the CT scan image on the 2020 file. And you can see here, maybe if I find the pointer, it will be better. No, I don't have the pointer. No. You can see here on the third vertebra on top, you have the upper level of the vertebra, which is fractured. So in January 2023, was referred again to the hospital with violent abdominal pain with digestive subocclusive syndrome. And it was suspected that it presented with a mesenteric ischemia that was eventually ruled out. A few days later, he complained about very strong lumbar pain, and it was found that he had a second vertebral fracture of T12, and maybe, but the plain X-ray were of poor quality, had another fracture of T8. So at this time, he was previously treated with cholecalciferol, 50,000 units per month orally. His dietary calcium intake was 200 milligrams per day, and the concentration of calcium in dialysate was 1.5 millimolar. He was also treated, and I don't detail all the treatment he had, with anti-platelets aggregant and anti-hypertensive treatment. So this is a CT scan that was performed at the time of his hospitalization when he eventually complained with lumbar pain. And you can see the previous fracture of L1 that was mentioned on the 2020 report, and T12 fracture, which was more recent. And this feature was rather signs of osteoporotic fracture with a posterior wall that was preserved. And no osteolytic features that could have make a suspicion of other lesion than bone fragility fracture. So the bone mineral density in March 2023 was performed, and we found a very, very low T-score in this patient who had a body weight of 53 kilograms for 1 per 57 meter, with a T-score at minus 4.4 at the spine and minus 4.8 at the hip. So do you want to comment then, and we'll see next the biology test?
Yeah, I think before we go on to the biochemistry, let's just pause here. So if I can just ask Neveen and Pablo, what do you think about the T-scores here?
Neveen, please.
Or Neveen, please. Ladies first. Oh, you're still on mute, Neveen.
I was on mute. Yes, I think they're extraordinarily low, because normally what you expect in patients with CKD is an artificially higher BMD than expected, and despite which you still have increased bone fragility equivalent to that of lower BMDs. But here it is very extremely low, and that means two things. First, that that obviously it's been sustained for a very long time, and it is probably as well multifactorial rather than be just an osteoporosis related to renal failure, which, as I say, patients even coming to transplantation after dialysis may have a BMD that's showing osteopenia and not osteoporosis. So that's the first aspect. And the reason why I'm saying it still underestimates it, because he also has problems, atherosclerotic problems. He's already had a stroke. So that means that his aorta is probably also calcified. So this is an overestimation rather than an underestimation. So it's very, very serious bone demineralization.
And the bone mineral density was not performed on the hemiplegic side.
Sorry?
The bone mineral density at the hip was not performed at the hemiplegic side.
But you have the lumbar spine also with very low density.
Absolutely.
And if I can correct, he didn't have any huge vascular calcification. The aorta was almost not calcified. But I'm very, very surprised by the case, because it was a man of 52 years old. So I am wondering if there was no any genetic disease explain this very, very extremely low bone mineral density. Some of, I mean, Gauche Fabry disease or other type of genetic disease.
Yeah. There's one question in Q&A which is relevant here, which is about TBS. Do you do TBS, Marie-Helene?
Yeah, we do TBS, but didn't bring any additional. With this very low bone mineral density, it doesn't bring any additional information.
Yeah. Okay. Right. I'll let you continue.
Okay. So this is the follow-up of a blood test, calcium, phosphorus, PTH, and vitamin D, and bone alkaline phosphatase. And rather than giving one measurement, I chose to show you the evolution over the last year. I mean, the year between 22 and 23. So you can see in a dark green calcium levels. And calcium varied between 2.2 and 2.45 millimole per liter. Phosphorus varied its pre-dialysis measurement, 0.5 and 1 millimole per liter. Vitamin D was low, between 10 and 18 microgram per liter, with normal higher than 30. PTH was between 300 and 150 picograms per ml. With our kids, the normal is below 65. And the bone alkaline phosphatase varied between 50 and 90 microgram per liter. And for us, the normal range is below 20 microgram per liter. And you see when occurred the second vertebral fracture. Should I keep on going? Okay. So then I also chose to show you the glucose serum levels, which were sometimes high. And then this is the nutrition parameters with albumin level, normalized protein catabolic rate, pre-albumin. And as you can see, the albumin levels was rather low. The pre-albumin lowish, I'd say, I mean, close to the lowish, lower part of the normal range. And the NPCR was low. I can show you here the ferritin level that kept increasing over the last months from 100 microgram per liter to 600 microgram per liter. And as well as CRP that increased, not that high, but up to 12 milligrams per liter. These are the post-dialysis calcium and phosphorus levels. So the calcium, post-dialytic calcium levels were normal or normal low, 2.5 millimole per liter, while the phosphorus remained at 0.6 or 0.8 millimole per liter. This is a bicarbonate that you may have asked. So I I prevented you asking, so he did not have any acidosis. So the next step were in April 20.
Sorry, Marie-Helene.
Sorry.
Can we? Can I just ask the panelists to comment a little bit about all those bone biochemistry? Any initial thoughts on them?
Do you want me to come back on the slide with the calcium, phosphorus, and PTH?
Yes, please.
Good.
I think one of the most remarkable feature here is a very consistent, very low phosphate, regardless of a reasonably normal calcium, apart some peaks, and the PTH that is actually falling with vitamin D. I know he had vitamin D supplementation. You said so, didn't you, Maria?
Yeah, he had, but probably didn't take it.
Okay, and the other thing, it was parent D, so it was cholecalciferol, wasn't it?
Yeah.
So he was never started with 125.
Not yet. We will see that later. Yeah.
And that consistency in that very low suggests that it's been going on for a very long time, which is also suggested by the changes, the radiological changes. And he probably would have had even more fractures than are visible. I mean, the T12 was already showing a grade 1, and that got very much worse in the second feature. So I just wondered, was that not detected when he presented so many years before, when he got lost to follow-up? What were the, do you have any?
No, we didn't have, we just had the CT scan, and I don't know, I mean, at this time, when he was put on dialysis, I mean, the phosphorus was high at this time, but it was in 2020. It was high, was, I think, 1.4 or something like that, but not low at this time. It was not low.
Okay. No, it's just lagging because it's been consistent.
Absolutely, yeah.
Very low.
Yeah.
Oh, Pablo.
Pablo, can you comment on the bone out force and the second vertebral fracture? Or you're on mute.
I'm sorry. I have two questions before commenting on BAP. The first one was we needed more information about the dialysis modality of these patients. He was in long nocturnal dialysis.
No, it was
frequent daily dialysis.
No, it was 3 times 4 hours, 3 times a week. KT over V was fine, and there was no special dialysis for this patient.
You can exclude that the two intensive dialysis could be because of
he had no intensive dialysis and no daily dialysis.
And the other question about the post-dialysis calcium levels that were not so high is the 2.5 millimolar. Which was the calcium concentration in the dialysate?
1.5. I told you that 1.5. Yeah.
Okay. So the other comment on BAP is it's only, I think it's probably because of the low bone turnover, the hypophosphatemia, which induced certainly a low bone turnover and probably an osteomalacia behind that. That's the reason the BAP are elevated. What about the total alkaline phosphatase? There was
a little bit high, but he has no hepatic problem, so it was a little bit high. I didn't plot it, but it was not remarkably high, but slightly elevated, slightly elevated, but no problem in the liver. So no possibility of cross reaction with the hepatic or total alkaline phosphatase.
And did you check for the other biomarkers of bone metabolism like P1 and P?
No, we don't do that.
5B?
We don't do that routinely. So we don't have TRAP5B, neither P1 and P.
Actually, the bone alkaline phosphatase is the most sensitive because the other ones are excreted by the kidney. Although he was having a diuresis, so it might tell us something. But the other thing is the bone alkaline phosphatase started going up after the vertebral fracture got worse.
So they were already high from November 22. It's in the 15 nanogram per ml. It's very extremely high. It's the double of twice the normal levels.
Okay.
Okay.
So I'll follow up our patient. So in April 2023, he was put under vitamin D orally. We increased the amount of cholecalciferol, 100,000 units per week for 4 weeks. But eventually we figured out that he was not taking the treatment because the vitamin D serum level did not improve. And we realized he had a very poor adherence to treatment. So we performed cholecalciferol injection of 200,000 units per month. And we increased the amount of calcium. They increased the amount of calcium carbonate 1 gram per day. And in July, the bone alkaline phosphatase went up to 100 microgram per liter despite treatment. It was put under 1-alpha, 1 microgram per day, plus calcium carbonate was kept at 1 gram per day. And in August, he had a bone biopsy. So this is the evolution of the case. As you can see on the right, that the bone alkaline phosphatase went up to 100 micrograms per liter, while the phosphorus increased a little bit, but it was still low, under 1 millimole per liter, and the calcium was rather normal at 2.3 millimole per liter, and the PTH did not change. Okay, this is a result of the bone biopsy. So the BVTV was low, 10%. The osteoid volume was high, 25%. The osteoid surface were very high, 62%. And the osteoid thickness was 28.9 micrometer. There was no double labels with the tetracycline labeling. And the osteoclastic surface was slightly increased at 5.2%. There was no evidence of myelofibrosis, nor woven bone, and it was aluminum negative.
Marie-Helene, can I just stop
Yes,
you there for a
sure.
minute? Some people may not be so familiar with reading bone histology. Could you just try and orient them a little bit?
Okay, so here we have a Goldner section where the mineralized bone is green and the non-mineralized bone is red. So normally the amount of red osteoid, which is unmineralized bone, is very low, below 5%. And here you can see on this slide that the amount of osteoid is very high. So I have to say that I took the picture of the site at the biopsy where the osteoid was the highest. In some other places in the biopsy, you can see still thick osteoid, but not that thick. And there is no sign of bone marrow fibrosis. So yellow, the yellowish dots that you can see between the trabeculae are the bone marrow. And you can see the white round ghost of the adipocyte in the bone marrow. And there is no signs of fibrosis, which is generally seen when you have with the staining some kind of pinkish staining close to the trabeculae. And you don't have, this is not the staining for looking at the osteoclast, but the osteoclasts were slightly increased, but not that high. So the final diagnosis was, as Pablo suggested, a full-blown osteomalacia. So should I go on?
Yeah, I think so.
So in September 2023, we realized that he has poor feeding, and as a matter of fact, the basis of his dietary intake was lemonade, and he drank 2 liters of lemonade per day, and that was it. I mean, very rarely one yogurt, and extremely rarely some protein intake, just like with meat or fish. And so he accepted because he was a very difficult patient, as a matter of fact, and we had very difficulties to find out what was his living condition and how he fed himself. So he accepted a paired dialytic nutrition, and he accepted also phosphorus supplementation, which was very hard for him to accept because he was very reluctant to take this phosphonurose, which has a bad taste. And 1 month later, we saw him worsening. He had diffuse pain. He could no longer walk. And we performed a technician bone scan. And we found that he has a typical bone scan of osteomalacia with multiple rib fracture and sacrum fracture, and also likely a fracture or fissure of the femoral neck on the the left side, sorry. It was a confirmation of the osteomalacia that was very severe on the histologic point of view. So eventually, I saw him very recently, and he's doing better after the transient worsening, fortunately, with still per-dialytic nutrition. And we have also taken care of feeding with a normal diet and trying to have him a daily help to cook for him or bring him food that he likes, because he's a very difficult patient. And we have seen a beginning of decrease of bone alkaline phosphatase, not at a strong decrease, and 85 microgram per liter. And he had 25 hydroxy vitamin D level, eventually almost normal, at 70 nanomole per liter, which is close to 28 microgram per liter. And his last serum phosphate and pre-dialysis level was 1.1 millimole per liter, and calcium and PTH was stable. So before maybe the comments of the panelists, I may summarize this case that illustrate bone fragility in a patient with chronic vitamin D deficiency, hypophosphatemia, and denutrition, who developed osteomalacia that responded to active vitamin D treatment, phosphorus supplementation, and refeeding. Bone mineral density and bone alkaline phosphatase serum level were used for the follow-up. And of course, we will perform a bone mineral density measurement after 1 year of treatment, which is very unusual because generally we recommend to measure bone mineral density after 2 years of treatment, but this is in osteoporosis treatment. But for osteomalacia treatment, we know that after 1 year, if the osteoid, which was not mineralized, get mineralized, you can, excuse me, you can see sometimes 25 or 20% increase in bone mineral density. So I chose this case, which is not usual. I agree on that. But I think that is to make people remember that fractures with low bone mineral density are not necessarily due to osteoporosis alone. We must not begin any anti-osteoporotic treatment unless renal osteodystrophy lesions have been specifically diagnosed and controlled. And it underlines the major role of nutrition in bone health and the use of bone alkaline phosphatase to detect and follow up mineralization defect. So I would be happy to have the comments of the panelists.
I think it's a remarkable case and teaches us a lot. I think that you're going to be very pleasantly surprised with the result of the BMD. I had the same experience with a patient with celiac disease, no CKD, that had a BMD of -4, and 9 months after starting treatment with it, like the one you gave with vitamin D and calcium, and improve the and giving her a gluten-free diet, her BMD was +1. So you can see remarkable improvements in BMD. So we'll be very, very curious to know what you find.
Yes, I agree totally with you, Neveen. I think it's a very, very illustrative and didactic case. And many things to say still. One of the people on the chat I work with Martina Cohen-Sola is asking if you did any MRI of the lumbar and thoracic spine, because she had 2 vertebral fractures. So to control if there were any other fractures on the spine.
So as a matter of fact, we didn't perform MRI, but we saw that he might have another fracture with a CT scan that was performed with a technetium bone scan.
And the femoral neck was also, there was a fissure, I think, in one of the sides.
Probably.
On the left.
Yeah.
And the other question I have is about the vitamin D metabolites. Did you measure at any time the 125 dehydroxy vitamin D to see if the liver was working, was transforming 25 in 125?
No, we didn't. We didn't.
You never give also calcitriol or 125?
I gave 1 alpha.
Okay.
1 alpha, 1 microgram per day, because he was not taking the cholecalciferol and obviously was not enough and doesn't work enough quickly. So with 1 alpha, it was much better. And the phosphate improved with the phosphorus supplementation, together with 1 alpha, improved rapidly afterwards.
And the other thing I'm wondering, why you didn't give administrate the phosphate supplementation by IV intravenous in dialysis?
Yeah, we did it also during the per-dialytic feeding, but also for Sonoros the day it doesn't go on dialysis.
We have a faucet in France. We can
Yeah, but I mean,
phosphate.
it doesn't want to go every day to the hospital, so he doesn't want to have any nurse doing a infusion during the day. He has no dialysis, so he's a very difficult patient. So
But
we had to discuss about it, and he accepted to drink the phosphoneuros for the day he didn't go on dialysis. He didn't want an infusion other than the one during dialysis.
We have seen 2 or 3 patients like the one that you presented, and we perfuse at the end of the dialysis the phosphate.
Yeah.
And it's more efficient.
Yeah.
Yeah. Marie-Helene, I want to say thank you. You can come out of your share screen now, actually, so we can see you properly if you want. In the meantime, just for the benefit of the audience, Pablo, 125D is very hard to measure, isn't it? It's not something that's available in clinical practice, certainly not in the UK. And also 125D level is so tightly regulated that you measure it once, you don't necessarily know whether, the next day that might be the same or not.
No way. Every lab is able to measure 125. And if you see that even if you give a ton of 25 cholecalciferol and you didn't have an increase in 125, you are being inefficient. And no effect on bone with 25, which the affinity is 1,000 lower for the receptor than 125. That's the reason you should measure it, and you should keep a 25 on the 60, 70 around per ml, and not only in 30, like the patient is today.
Okay. There are a couple of questions on the Q&A, if I may, with regards to bone alkaline phosphatase. So I think we've mentioned already about the fracture, and bone alk phos could go up with that as well. But Martin also raised the question whether all the pseudo fractures and all the lesions in the ribs would also make bone alk phos go up. But I think in this case, Marie-Helene, you have proven with the bone biopsy that is the osteomalacia that's probably the main reason why the bone alk phos is really high.
Yeah, I mean, there are 3 conditions when the bone alk phos goes up in CKD: when you have very high turnover, when you have osteomalacia, or after fracture, especially femoral fracture or hip fracture or a pelvic fracture. So of course, if we only measure that one and we don't have any follow-up, we are kind of blind with an elevated level of bone alkaline phosphatase. But I think again that when you combine all the information going up of alkaline phosphatase plus hypophosphatemia, then you can suspect the osteomalacia. I mean, this case it was rather caricatural. Sometimes it's much more difficult.
Yeah. And also another question that I often get, and any one of you can answer this. Some people may have not got any access to bone alkaline phosphatase, so they're asking, is it okay just to measure total alk phos and monitor response to treatment just using total alk phos?
Yes, because it would be increased. I mean, if you can't measure bone alkaline phosphatase, you do need some indicator that the treatment is working. And we didn't, I mean, originally some years ago, we didn't have the possibility to do it outside the research context. So we did use total alkaline phosphatase. And actually, one thing here, one small comment, I would actually even increase the dose of 1 alpha and until the alkaline phosphatase, the total alkaline phosphatase, if the bone alkaline phosphatase is not available, until it starts coming down. So this is what I use to actually titrate the amount of 1-alpha that is necessary. Calcitrol is it's 1.5 sort of equivalent doses, so you would need less calcitrol, but sometimes 1.5 of 2 micrograms of 1-alpha until the bone turnover steadies, and then start tailing it down to 1 microgram again. So that might speed up the process with all the other measures that you're taking, Marie-Helene. But
Okay.
just a thought. And alkaline phosphatase is fine. Yeah.
You will give it by orally or by intravenous?
No, orally.
Oral. 1 or 2 micrograms. Okay.
Yeah. Marie-Helene, you were saying you're giving it intravenous or orally?
No, it was given orally.
Orally as well.
Yeah. So I didn't dare to go up, but it's interesting suggestion.
No, it is just on a low side, and as a safety measure, if you follow the total alkaline phosphatase, it's just in the routine biochemical panel anyway. So if you, as soon as it starts coming down, you know that that's the level where maybe you carry on for a few weeks, but then you would have to tailor, accordingly tailor the dose of the 1-alpha. But 1 microgram with this pathology might be
too low.
and it might take too long to heal. But,
I have one question for Marie-Helene. What is the potential role of low PTH in the low mineralization of this patient? And I'm asking because the physiology and about sclerostin, we didn't measure. I think it would be fine, good and worse for us to understand his clinical case, to have the FSGS23 and also to have sclerostin levels. To see if the PTH is not working at all.
Yeah, especially sclerostin level might be reliable because, as you mentioned, he has no vascular calcification. So literally, probably a less probability to have sclerostin originating from the vessels. So no, we didn't measure that. And FGF23 is a very interesting suggestion.
That would be very interesting.
But yeah, we didn't do that. Okay. Well, something that made me think that he had no problems with the FGF23 RTIO. It's because when we measured phosphorus in the urine, there was no phosphorus in the urine.
And he didn't have any other endocrine disorders like hypogonadism and.
Oh, I didn't measure testosterone levels. I mean, this is something that we are going to deal when he has healed his osteomalacia, then he will probably not normalize his bone mineral density. I mean, I hope we get to minus 2.9 or so, or minus 3, but probably we will not normalize, and he will remain with osteoporosis definitely, and then we probably have to deal with the osteoporosis treatment. But then we will probably perform the testosterone level and see what happens. And also, the guy, is immobilized. He has this hemiplegia. He doesn't walk much. So you have all this immobilization role on bone loss, which is probably important together with hemiplegia when you look at the right side. So it's a complicated case, definitely. But we will have to deal with osteoporosis once osteomalacia is cured.
On the bone biopsy, did you rule out other causes of osteomalacia, like fluoride, strontium?
No, we didn't. We looked at aluminum. We don't measure fluoride, and he was not drinking eau de Vichy, as you know. So he was only drinking lemonade, which doesn't have fluoride in it. So we didn't look at that. No. But if he had not responded to refeeding, probably we would have looked back on to the biopsy. That's a very good suggestion.
Can any of you comment on the perhaps the prevalence of osteomalacia in people with CKD? And leading after that one is one question which is really interesting. From the biochemistry, we know he has low serum phosphate. So the question is, do we really need a bone biopsy to improve his nutrition? So Pablo, you deal with a lot of dialysis patients, so do comment.
No comment. I don't know if Marie-Helene wants to comment.
I am not sure that the biopsy was useful because I mean, especially when we performed the biopsy, we were not I was pretty confident with the final diagnosis. But I was happy to have the diagnosis when it worsened in September with all this fracture, because I knew that all this, what was going on was due to the severity of the osteomalacia, that I could not really assess with the level of bone alkaline phosphatase, because the most severe osteomalacia I saw in CKD patient had much higher level of bone alkaline phosphatase in the serum. So retrospectively, I think it was a good thing to perform the bone biopsy because of the transient worsening of the patient in September and October. Yeah.
This scintigraphy scanning was enough for the diagnosis.
Yeah, absolutely. I mean, if he had performed this, presented with this diffuse pain in July, probably I would not have performed the biopsy at this time, and he was in a very bad shape.
But I would have done the biopsy as well to exclude, because that severe osteoporosis is also typical of secondary osteoporosis. So exclude mastocytosis.
Yeah.
All the other diseases that can make you lose bone very quickly. I mean, it was difficult to establish. I mean, there was no comparison BMD before or after, so we don't know how long it took him to get to that stage, but you can lose a lot of bone very quickly if you have secondary osteoporosis because of any intoxication, any mastocytosis, any of those myeloma. There was no indication of that, but he had the pain, he had the fracture, it was multiple. He was not hypercalcemic, but and his background nutritional status actually signaled as well that was so severe that it may have been responsible, but it's so unusual that I would have absolutely done a biopsy as well.
And to answer the question about the frequency of osteomalacia in CKD patient, in my experience, it's still a rare disease. But again, we have been discussing this lengthily in the Europe group, because it depends on the diagnosis criteria that we use for the biopsies. But I think we see now osteomalacia in post-transplant patients with severe hyperparathyroidism and hypophosphatemia with functioning kidney. So this is not an extremely rare condition. And again, the case I present here with the hypophosphatemia due to the poor nutrition is rare, but we can see sometimes osteomalacia with acidosis, for instance, or with vitamin deficiency. We don't see anymore in our country aluminum intoxication with osteomalacia.
No, aluminum intoxication was the leading cause of osteomalacia in the 80s.
Yes,
Once that was excluded, and electrophoresis and whatever in all units, the water is being treated properly at the moment. And sort of over the past few years, it's mainly the combination of either vitamin D deficiency, just square and fair, kidneys not working, not enough 125, and hypophosphatemia is also one of the major causes.
What puzzles me sometimes in patients, it's sometimes we find osteomalacia on histology, and there is no acidosis, there is no hypophosphatemia, and no vitamin deficiency. So then we have to think about the role of FGF23 on bone mineralization, which have been suggested by some fundamental papers. FGF23 might have a deleterious role on bone mineralization itself, or locally. So this we don't know, and this remains to be looked at.
After transplantation, it seems the high levels of FGF23 seems to linger on for quite a while after transplantation. I've had patients with phosphate of 0.4, totally asymptomatic after transplantation, and FGF23 was high. We didn't have pyrosumab at the time. We didn't, we didn't have any way. I wasn't going to give a phosphate because it would suppress 125 and increase a phosphate anyway. And the patient was fine. So I just grinned and bared and waited. And it took a couple of years, and then he was fine. But I did monitor him like a hawk, and he never fractured. And the biopsy showed osteomalacia. So
in our experience at the La Universidad Hospital with Martina Cohen-Soral,
Yeah.
the prevalence is only 3% for the last 10 years. But we are seeing more and more patients with osteomalacia because of very intensive hemodiafiltration and long dialysis. And the other thing, don't forget that if you have a very chronic low calcium, because we are using low calcium in the dialysis site, this is also a cause of osteomalacia. No calcium enough in the ingestion, by the diet, low phosphate, and low vitamin D. But calcium is also very important.
So it's multifactorial rather than one thing.
Yes.
Yeah.
Just
Jody also made a point that for patients who come from North Africa, we need to remember as well, they may have aluminium-induced osteomalacia still, although that's not obviously common in Europe anymore. Martin Cohen-Solal has put a question here. We should invite Martin one day as a panelist as well.
Sure.
Next time.
Yeah.
Definitely.
So Martin is asking, when you repeat the DEXA in a year and the BMD has improved, and let's say the patient hasn't developed any more vertebral fractures, then but may or may not still have osteoporosis, would you consider other treatment, or would you just wait and see?
So I don't know with this patient what you will do, but it is what I do with osteomalacia. I perform a bone mineral density every year, and then when I have a plateau, I think the osteoid is all mineralized. And depending on the final T-score, I will see whether I have to deal now with pure osteoporosis and then consider anti-osteoporotic treatment. But I will do that only if bone alkaline phosphatase levels have normalized.
I wouldn't jump in directly into
No, I will wait.
any
Of course.
bisphosphonate or denosumab or
Absolutely.
PTH or
No way.
I think at the moment it hands off is probably the best. I mean, there are indications for, but generally bisphosphonate would decrease bone turnover further and may increase bone fragility.
Again, it's with normalized bone alkaline phosphatase and a plateau bone mineral density, which maybe in the 3 years from now or 4 years.
Yeah, but then you treat the biochemistry rather than treating the patient. So I think you have to monitor them and try and find out if the BMD keeps falling. This is a different situation. Then need to investigate more and find out why. But it's not really the experience over the years. Anyway, my experience. So I have treated patients with bisphosphonate. I haven't treated anybody with denosumab because in any case, the offset rebound is far too dangerous if a patient has got increased bone fragility anyway, and you would have to give bisphosphonate afterwards anyway. So, so I think, except if there is a very good indication for, I wouldn't automatically decide if the osteomalacia improves, then I would go straight for, I would wait for the bone mass to increase as much as possible and then decide. And you might be pleasantly surprised that it would go higher up. The problem is the microarchitecture is probably now disturbed anyway. So it will, it's not likely to go up as much as if it was celiac disease or something more straightforward, where it's pure demineralization rather than loss of microarchitecture.
Let's ask one more question to Marie-Helene. Imagine that this patient in 10 years, we measured FHUS23 is very, very high. And do you will treat him with antibodies against FHUS23, like for the X-linked hypophosphatemia?
I don't think this will happen because for me, the low phosphate is due to nutrition only. So I have no idea what I would do. I mean, giving birozumab, I know that already, convince a nephrologist to give phosphate to a CKD patient is difficult, but prescribing birozumab in this case, I don't think so. I don't think so, no. There is another thing that I would like to underline is when we began to treat the patient, he worsened. And the nephrologist told me, oh, your treatment is not working, we have to change. And this is something which is highly different between the rheumatology and the or endocrinology and the nephrology. I mean, you have the bone is an organ that reacts slowly. And when you are sure of the diagnosis, you have to wait for several weeks and sometimes months to see an improvement. While the nephrologist, you have hypertension or acute renal failure, and then you have to have a reaction right away. So this is the main difference between bone and kidney.
Excellent. There are a couple of questions on the anabolics, actually. But we've said that we're going to sit tight on this patient. But let's say, you know, you've got the alkaline phosphatase normalized, and you scan again 2 years later, and there are more vertebral fractures, for example. Is there any role in using anabolics?
Well, again, I think what Neveen said is sound, and I will be very, very careful and cautious if or when I'll treat this patient for osteoporosis after he has cured his osteomalacia. But for me, if a PTH is not high and he has 2 vertebral fractures, maybe I would consider teriparatide. But again, I will be very cautious with this patient. And I mean, I prescribe teriparatide in CKD patient with more than 2 vertebral fracture. But in this case, I will be very cautious.
Marie-Helene, he
Yeah.
had a CRP, high CRP.
Yeah.
I'm wondering, how were the other hematological parameters, like hemoglobin,
So,
the
yeah.
erythropoietinosis? This patient, he was very anemic.
No, he was not very anemic. He was treated with erythropoietin, and he had this over time transient increase in CRP. But what bothered me was the increase in ferritin levels, for instance, while the hepatic exploration was negative. So I don't know what to do with these ferritin levels, which is also associated with the inflammatory state.
You
But
you should try to give one of the HIF stabilizer.
Yeah, yeah.
PhD inhibitor.
If we are sure that this treatment doesn't is bad for bone first.
It will be probably better for the bone.
We don't know yet. I mean, we have an ongoing trial on the bone health in our Rodazuxa. So we'll see what happens.
Neveen, you mentioned about using anti-resorptive, bisphosphonates in some of these patients. So one of the question is there a licensed bisphosphonate for dialysis patient, or any real world evidence on that? Yeah.
No, actually, there are some data. There's obviously no randomized controlled trials, and the data are scarce, and it's not enough. So it is really individual decisions, and bisphosphonates would be useful only if you have a high bone turnover that you can't control with active metabolites of vitamin D. So because the main object of giving bisphosphonate is to suppress the bone turnover. And there are some bisphosphonates that are milder than others, and some that have a very high residence in the skeleton. Once they're in, and they can be there for 6-7 years, some of them. So I would certainly, and if I had a choice, when I was in Sheffield, I used clodronate, and this is not very much used. It's still in the market in some countries, but not in all countries. It is a milder bisphosphonate. It's not an amino acid containing bisphosphonate. So the mechanism of action is different, and the residence in the skeleton is shorter. So this would be, if available, I would go for that. And I would not treat somebody with a normal turnover or low turnover with the bisphosphonates. And I would just consider romosozumab if you have an adynamic bone disease that doesn't budge, that doesn't move, and you try to really give it a kick. So you would do either PTH or you would do romosozumab, except that, again, there are no data in CKD patients. And although the vascular risk has been a bit sort of, defunct and, as possibly not that relevant, it is still something to take in consideration. So I would only give the anabolics if I have an ABD that is really very resistant to any form of stimulation. And I would give the bisphosphonate. I would not give a bisphosphonate in a situation of okay osteoporosis and fracture, but a normal or low BMD. Bone turnover.
Low bone turnover.
Yeah,
I agree with you.
So these are the general rules. Of course, you treat every patient individually, and I would still give as much active vitamin D because it actually it would work on to control the PTH. It would work to increase calcium absorption from the gut. So it has multifactorial way of working, and you can monitor it. You can increase it. You can decrease it, and it's a shorter half-life than giving the parent vitamin D, which you still have to correct. You still have to have a decent dose, but you manage that extremely well. I mean, 70 nanomole per liter is royal for a cholecalciferol, a 25 hydroxy D level.
It's 70 nanomole per liter. It's not 70 nanograms. It's nanomole.
Nanomole per liter.
Yeah. It's in the 25.
So basically, you say you have to have it more than 50.
Yeah.
And for the treatment of osteoporosis, the advice is have it at 75, more than 75. 70 is nearly there. It's as good as.
Yeah.
So this is essential. And what I used to do is give both. So I would give the cholecalciferol to get my 25 hydroxy D normal, and I would add 1 alpha calcidol until the alkaline phosphatase stabilizes, starts decreasing, and then the average would be 1.5 microgram, but after loading the patient with enough. So that works to actually stabilize at least the mineral side of things.
Thank you, Neveen.
My pleasure.
Right, we've got the last few minutes. I'm just going to close. Thank you, Marie-Helene. That was a really good case, and just demonstrate to us, although the prevalence of osteomalacia is low, we must not forget that it does happen, and the right treatment is important in those patients. So I'll skip that one. So I want to thank everyone for coming. Please do not forget to put in your calendar January 15th to 17th, 2025, and come to Leuven for the winter meeting. It's always useful. And also, if you like this case conference, do come to the ones that we've planned for the rest of the year in May, September, and November. And I'm sure Martin will be one of the panelists at some point, Martin. And anyone else have got any comments from the panelists? No, otherwise I would like.
Excellent case, very, very, very interesting. Thank you, Marie-Helene.
Yeah, thank you to
Everybody.
you. Thank to you, Neveen and Pablo. And
no, thank you for the invitation. I appreciate it. It's a very nice case.
Yeah, thank you, Neveen and Pablo. It's really good to draw the knowledge from your vast experience in CKD-MBD. So fantastic. I'm sorry I didn't get to all the questions that are on the Q&A, but hopefully you've learned lots today. So thank you, everyone. And with that, I close the session. Goodbye.
Bye.
Bye.